Right, I'll make a start then. So, afternoon, everybody. It's great to see everyone join us today for the ePrescribing Masterclass. And we've got a great lineup of speakers today, which you'll be able to see on screen. We've got three different areas that we'll be covering. Asil and Aliyah will be talking about designing and piloting, testing an anticholinergic medication index clinical decision support system for the use in hospitals to support safe prescribing for older people at risk of medication-related harm. And then we're going to have an overview of clinical safety. And finally, the electronic prescribing learning lab update from John. In terms of the format of the webinar, so it is going to be recorded. We have moved across from Teams from the GoToWebinar platform, so I hope everyone's been able to join. And the recording will go up as usual on the Futures website. And you will have the option, if I can ask everyone to mute for now, but there is the option after each presentation for you to come off mute and ask questions directly to our speakers. Alternatively, you can use the Q&A function to ask any questions whilst the presentations are going ahead. And in terms of just for those of you that are new to the ePrescribing Masterclass, I'm Amna Patel, Clinical Fellow at NHS England and a pharmacist by background. And the whole purpose of these masterclasses are to share learnings from the optimization of e-prescribing systems. And it's really for opportunity for professionals to come together and share their experiences of using these systems. And we always do ask that if you are interested in presenting some of the work that you're doing at your organisation, please do get in touch with Sarah. Her details will be shared at the end of the presentations. So I'm first going to introduce our first speakers. That is Asil and Aliyah. And Asil is a registered pharmacist by background and a senior research fellow at the University of Leeds. She's completed a PhD in prescribing and patient safety research, exploring the clinical reasoning processes of non-medical pharmacists and nurse prescribers. And she's worked on a number of medication and safety projects in primary, secondary care and prison settings, all with a focus on developing digital health tools. Aliyah is the EPR lead pharmacist for Calderdale and Huddersfield Foundation Trust and Bradford Teaching Hospitals Foundation Trust, and she recently completed the Digital Health Leadership Programme with the NHS Academy and Imperial College London. So I'm going to hand over to Asil and Aliyah now. Thank you.
Thank you very much. Thank you. So today I'm going to present a grant proposal from a recently awarded RFPB grant and some preliminary discovery work that has been done to date. Next slide, please. So anticholinergic medicines are commonly prescribed in older adults over the age of 65 for a multitude of conditions, such as urinary incontinence, intestinal spasms, and other conditions commonly experienced by older adults. And we know that the available prevalence estimates show that around 20% of older adults are prescribed anticholinergic medicines. And these adverse effects increase as we age and are associated with mental and physical decline. Next slide, please. So recognized acute adverse effects include an increased risk in delirium and falls, and long-term adverse effects would include dementia, loss of physical function, and eventually loss of independence. And these adverse effects are common reasons for hospital admission and inpatient harm. And around 30% of older adults and up to 50% of orthopedic hip fracture patients experience delirium during a hospital stay. And about 250,000 inpatient falls are reported annually in England and Wales. Next slide, please. So we're familiar with the different calculators, anticholinergic burden calculators that already exist. And the way they've been developed vary. So anticholinergic burden is usually either the calculators that exist either are measured against various scores that reflect anticholinergic properties. So either derived from in vivo or in vitro studies on patients' physiological responses, or by scoring them based on clinicians' opinions. However, these currently existing anticholinergic burden calculators don't account or haven't been optimized to predict adverse outcomes such as delirium or falls using large data sets. Next slide, please. So in order to sort of bridge the gap regarding this, we developed something called an anticholinergic medication index. So it began with, it was a HCR-funded research project where the aim was to develop this anticholinergic medication index and roll it out into GP practices. So to begin with, we conducted a literature search, and there's approximately 600 medicines that currently exist with anticholinergic properties. So we did a literature search to find the most commonly prescribed anticholinergic medicines in the UK, and that gave us 89 medicines. And there's a already existing data set known as Connected Bradford, and it's a system that links primary, secondary, and social care. And we used Connected Bradford from 150,000 patients to develop a prognostic model on patients over the age of 65 and included those 89 most commonly prescribed anticholinergic medicines. And in addition to that, we added the predictors for falls and delirium. So other predictors included osteoporosis, Parkinson's disease, and many others. And the idea was that this model would quantify the association between each anticholinergic medicine and the adverse outcome of delirium or falls. And once we had this prognostic model developed, we translated it into a workable calculator, which we're calling the ACME calculator. And that would calculate the burden of potentially harmful anticholinergic medicines. We also co-produced decision support tools, which included a training package, and that was co-produced with clinicians and patients. And we trained GP pharmacists before we rolled it out into GP practices to assist them in identifying patients at risk of harm from anticholinergic medicines and invite them for a structured medication review. Next slide, please. So the current problem with anticholinergic burden calculators is that, number one, they are not embedded into EPR systems. So you would have to manually enter each anticholinergic medicine into, for example, an external web page, and try and hope that you can calculate the anticholinergic burden for each patient. And in addition to that, there's just far too many anticholinergic medicines to remember. So having something integrated or embedded within an EPR system would be very useful, and especially in hospital practice. Next slide, please. So the aim of this project is to design the anticholinergic medication index, and we're calling it ACMIX just to differentiate it from the original project that was for GP settings. So the anticholinergic medication index clinical decision support system, so ACMIX, to optimize prescribing of anticholinergic medicines in secondary care, and also then assess the feasibility of its use as part of routine care in acute hospital wards. Next slide, please. So there's 3 stages to this project. The first one is actually designing the ACMIX itself using a method called contextual inquiry, and then embedding it into an EPR system, and then doing a feasibility study to examine the feasibility of its use in secondary care. Next slide, please. So in order to design the ACMIX itself, we chose a method called contextual inquiry, and it's basically a user-centered approach and a field study method that's used to design approaches in technology development. And it's very suitable for complex and dynamic clinical environments such as secondary care. And what we'll be doing is we'll be observing one-on-one a group of healthcare professionals who are working in the geriatric wards and orthogeriatric wards of 2 hospitals. And we would be gathering information about how they currently sort of conduct their medication-related processes, such as medicines reconciliation, medicines optimization at the point of admission and during inpatient stay, and how they complete discharge summaries, and observing and capturing what information is presented on the screen and how we can potentially incorporate the ACMIX into their workflow from the normal work processes that they currently do. Next slide, please. So the information that we gather would allow us then to interpret the findings by coming up with key ideas around how they sort of key themes around what they currently do, their behaviors around the EPR system while they're undertaking medication-related processes. And it would also allow us to provide insights on it would provide us with insights on the patterns, the situations, and the needs of the user. And we would also then use this information to present it to other clinicians and patients to ensure that there's like a shared understanding of the design that we want to eventually come up with. So there would be design ideas coming out of the contextual inquiry observations, and then we would hopefully use that as well to refine the training package that was already developed in GP practices so that it's more suitable for secondary care. And in addition to that, because we're aware that we're developing something within one vendor system, so one particular EPR system, in our case is Oracle Cerner, we'll also be creating a technical specification document that details how to extract and utilize data from the hospital EPR to integrate ACMICs so that it's more generalizable to other hospital EPR systems. Next slide, please. So once we've now, we've developed the ACMICs itself, and we've got the technical specification as well, and we've refined the training package. We would then do a pilot feasibility study of it. So we would have at this point rolled out the training package, and we would interview healthcare professionals and patients to explore how this was implemented and to try and understand what they understood of the ACMICs itself as a calculator. Did it fit into their workflow? Did it support patient discussions? And how can we sustain it as part of their normal routine practice? And all the information that we would get from that would also help to further refine the training package, and then also come up with a good practice guide on outlining the implementation of ACMICs into practice. Next slide, please. So this is a whistle-stop tour of the grant proposal. We've also been doing some discovery work to understand what is within the arts of the possible in terms of embedding ACMICs into a hospital EPR system. So the work that's been done to date, which will be presented shortly by Alaya, explores the technical capabilities of Oracle Cerner. It's important to note that even though we also explored the different ways in which ACMICs would be displayed, this is probably going to change based on the findings from the contextual inquiry methods when we start the research project itself. Over to you, Alaya. Thank you.
Thanks, Cecile. Hi, everyone. As mentioned by Amna, I'm Alia. I'm the EPR lead pharmacist for Calderdale and Huddersfield and Bradford NHS Trusts. I'm the last minute cover for a colleague, so you might need to bear with me at points. So as mentioned by Asil, during this preliminary phase, we wanted to explore whether an ACME score can be calculated after prescribing or discontinuing an ACME medication. We also wanted to find out where it might be possible to display the ACME score. I'll talk about some of the areas that we've come up with in the next few slides. If there's other Cerner trusts on the call, which I'm sure there will be, we'd be keen to hear from you about whether we've missed any areas. And we'll start making decisions about where we'll actually display the scores as the study progresses with clinical observations and further stakeholder feedback. So this screenshot that you're looking at is from the requests and care plans area of our EPR, which is where all orders are placed, including for prescriptions. It's the action of signing the medication order or prescribing it for the non-Cerner trusts on the call that then calculates the ACME score. We decided to not present the ACME score at this point for various technical / logic related reasons. So in this screenshot, what you're seeing is the anticholinergic medication order of Alvarine being signed. Well, it's now being signed. So the ACME score is now presented in a pane on the left-hand side of the screen. We usually use this particular pane that's labelled related results to display things that prescribers might be interested in. For example, we might display weight or whether the patient's got an AKI, etc. Prescribers can get a breakdown of the ACME score through a few further clicks. from the result itself, as you can see in this screenshot. So a further ACME medication order of amantadine has now been signed, so the ACME score has been recalculated, and it's increased from 0.5 to 2.8. And again, prescribers can get a breakdown of the components that make up the ACME score through a few further clicks from the result itself. I just wanted to note here that this tab's only showing us the two prescribed ACME medications with their respective scores. I'm not sure if you mentioned, Asil, but no, you did. There's actually 89 medications that can contribute a score. It took us quite a while to figure out how to not display all the ACME medications that aren't prescribed in this box. I hope that was okay to understand. There's quite a few double negatives there, which I apologize for. Okay, and then in this next screenshot, just shows that we're about to discontinue an ACME medication. So we're discontinuing the Alvarine here. And Alvarine had a score of 0.5, so the score's now decreased to 2.3. And again, just demonstrating that you can access a breakdown of the score at any point. And to answer our initial question about whether it's possible for an ACME score to be calculated and presented within the EPR, we could safely answer yes to that question and then begin our exploratory work of where else it might be possible to present the score. Now, this is an area of the EPR that was built for pharmacy use, but there's also a doctor version of this. We've used the pharmacy version for proof of concept, and this area of the EPR brings together a series of components that contain information that would be useful for a review. It's supposed to be a type of one-stop shop for reviews, and you can carry out various actions from here too. We found that it was possible to add an ACME component here, as you can see. And another click enables presentation of the ACME score trend, which is the graph that you can see within this screenshot. Okay, so it became clear following initial stakeholder conversations that this reconciliation screen is where prescribers carry out most of their prescribing and deprescribing actions. Again, for the non-Cerner folks on the call, this is usually where documented pre-admission medications are converted to actual prescriptions on the drug chart that can then be administered. Prescribers can also use this screen to prescribe medications from scratch. We found that it was possible to present the ACME score here too, which was great news. And this is the Pharmacy Care Organizer, or PCO for short, that brings together lots of information in a single dashboard type view for pharmacy staff. We're confident that we'd be able to pull the ACME score into here too, but we've not yet attempted it. It's a similar sort of thing for what's called the doctor work list that brings together lots of information in a single dashboard type view for doctors. Again, we're confident that we'd be able to pull the ACME score into here too, but we haven't yet attempted it. And as you can probably appreciate, there's lots of potential for displaying ACME scores at a ward level, but these dashboards aren't usually as good for a hospital level view. just because it'd just be way too much information. We'd need to involve our BI teams, I think, for a robust hospital view solution, if that's something that comes out of the study as a requirement. So we've also now answered our question about where it might be possible to present ACME scores. There is always a fight for screen real estate. So although we've identified all of these areas that we might be able to present ACME scores, we'd still need to have those screen real estate prioritization discussions with stakeholders. And again, we'd be keen to hear from other trusts about any areas we might have missed or any other pertinent considerations. And I'll hand over back to Asil.
Thank you, Ali. So now that we know that it's within the remit of the possible, so now the next steps for us is to make a start on the actual research project itself, which is due to begin in May of this year. So we'll be undertaking the contextual inquiry observations that I just mentioned. There'll be a lot of stakeholder input as well, and looking into ways of producing the technical specification that I mentioned as well. Along with that, there'll be the training package and implementing it into practice to also come up with a good practice guideline. So watch this space. So that's basically it. So thank you so much for your time, and happy to answer any questions that you've got. Thank you.
Thank you, Asil and Elia. That was really interesting to see about the work that you're doing and the future research that's planned for May. I'll first open it up to the audience. I think you were asking if there was any Cerner stakeholders on the call or users on the call. So if there is anyone that wants to share any comments or feedback to Asil and Elia, please feel free to come off mute, because Teams allows us to come off mute now, which wasn't possible before. Or if anyone's got any questions, I don't think there's any in the Q&A. Oh, yeah, there is one. Sorry, there is a Q&A. So there's a question here around where is the trend information pulled from? Is it across lifetimes or individual admission periods? It looks like a fantastic as a concept, and I would hope it would be able to be added to different EPMA systems.
I'll take that, Asil. It's at the moment it's looking at the current encounter, and it's looking at the current prescriptions that are on the encounter, and whether it would be able to add to different EPMA systems. Certainly from a Cerner Trust point of view, it's really easy to share what different trusts have done, and then, as Asil mentioned previously, there'll be a technical specification that'll be released for non-Cerner trusts.
Is there a timeline for the sort of training package and technical specification to be released? Have you got like a rough idea of when you think you'd be sharing that work?
So the project is going to go on for a couple of years. So I'd suspect maybe within a year, hopefully we should have the technical specification done, if not less than that.
And is there anywhere where people could probably find out more about the work, or will you just be doing updates, on various platforms?
I think at the moment we're going to be doing updates on various platforms, but any ways to disseminate would be most welcome. If there's certain groups like this call, the groups within it would be great. The more that we can sort of increase the outreach, the better.
I'll just open it up again. Does anyone have any questions? Happy for you to come off mic or add them to the Q&A. And I'm sure once you've done your research and the next phase of the work, Asil, I'm sure you can come back to the webinar and present findings. I think people are really
Absolutely.
interested to see that, so it'd be great. Gemma.
Hi, Lion, Asil. Thanks for a great presentation. My name is Gemma. I'm from Royal Free Trust. We also use Oracle. I just want to check, has it been considered around communication to GPs on like discharge around their ACMI score? Because I think that's come up with us, not me personally, I think another trust, their ICS have been asking around communication of these scores on discharge.
Yeah, Ali, if you want to chip in as well, because I remember we did discuss it quite early on in terms of adding the ACME score in the discharge letter. Ali, do you want to comment on that?
Yeah, we haven't made any hard decisions about whether we're going to present the ACME score on discharge letters. It's something that we'll discuss with stakeholders as the study progresses. But yeah, definitely something that we're thinking about.
Gemma.
That's great, thank you. Can I also check, are you working with, do you have like an Oracle Health meds consultant working with you on the project, or is it all in-house? So
Yeah, yes, it's all in-house. We've got a contractor working with us that's done most of the discovery work. Yeah, but yeah, no Oracle consultants are working on the project.
okay, yeah, and I'm just thinking around ease of it becoming kind of like model, the kind of content that anyone who joins Oracle would have access to. But yeah, I hope it goes well. It must be very complex logic in the background calculating the score. So good
Yeah,
job.
definitely.
But I'll be interested once it's all finalized. But yeah, thank you.
Thank you. Yeah, just to let you know, Gemma, as well, that the Prashant, who is meant to be presenting with us today, he's an ex-consultant for Oracle, I believe. So it really helped as well to have sort of his knowledge and his experience involved in bringing this work together. But like you said, there's a lot of hard coding in the background. We're talking about something, from what he mentioned, was something that was developed back in the 70s that has been not particularly easy to work around.
Thank you. There was just one final question in the chat about if it would be worth exploring the calculation of the ACME score on admission versus discharge.
Yes, and sorry, go ahead, Asil.
Yeah, so yeah, this is what we're looking into for the feasibility part of the study. So just to see if there's been much of a difference between when someone was admitted into the hospital versus when they were discharged, and if that was as a result of the availability of the ACMEX itself or not. So that's a part of the feasibility exploration work as well.
That's great. And yeah, thank you both for joining us today. Lots of people are interested in this, so we'll watch this space and hopefully see you again in the future with the follow-up.
Thank you.
Thank you very much.
So I'd like to introduce our next presenter, and it's Hodi. Hodi is a clinical lead at NHS England, and he formerly was the Senior Clinical Safety Officer and Medical Device Regulatory Consultant at Safe Hand. And prior to that, he was a Senior Informatics Pharmacist at a GDE Trust. Hodi is going to present an overview of clinical safety. So I will hand over to Hodi now. And like I said before, if you've got any questions, please put them in the Q&A. Thank you.
Thanks, Amna. Hi, everyone. Can everyone hear me and see me changing the slides effectively?
Yes.
Is that working? Yeah, great.
Yes.
So what I want to cover today is just quite a very brief overview of the clinical safety standards. It's going to be quite high level because we can't really cover the breadth of this topic effectively in 20 minutes. What I'm going to hopefully try and do is give some adequate time at the end for questions. So if you guys have more specific things that you want to explore a bit further, hopefully we can do that there. But just cover the standards from a high level. Hopefully a lot of these things will be quite familiar with most people on this call, and then talk about the deliverables, some of the key requirements within the standards. It's difficult to sort of have any sort of meaningful what good looks like, again, in the timeframes provided, but maybe some tips about how you achieve like a good approach. And I've tried to put some example hazards together, which I expect to see in most DCV 160 hazard logs. That might help you guys if you're in that process of putting together a hazard log, and then finally finish with some challenges. So the standards were created back when NHS Digital was an entity, and there's two of them. They're two sister standards that mirror each other. One is DCB 0129, which is the application of clinical risk management in the manufacture of health IT systems, and that typically applies to the suppliers and vendors. And then there's DCP 160, which is the application of clinical risk management in the deployment and use and implementation of health IT systems. That typically applies to the healthcare organisations that deploy them. They're mandated by NHS England through the Health and Social Care Act 2012, and they form a key part of DTAC, the Digital Technology Assessment Criteria. And it was really DTAC, when it was introduced best part of 3 years ago, that accelerated the adoption of these standards. So initially, a manufacturer will undertake DCP 129. So they'll undertake a risk assessment on their product. They'll create a set of deliverables, and they're mandated to send across the hazard log and clinical safety case report to the healthcare organization that is deploying that health IT system. The healthcare organization is then required to undertake their own risk assessment based on their own unique implementation and use of that health IT system as per DCP 160, and the manufacturer's hazard log and safety case report will help to inform that assessment. They'll also incorporate any what we call transferable controls. So they're the sort of controls where a manufacturer can't sort of implement themselves and they're pushing onto the healthcare organization. So for example, it might be that the manufacturer will say, we can provide you with training resources and material, but it's up to you to ensure your staff are trained and signed off. Or it might be that we will do certain testing, but it's up to you to do your own user acceptance testing. Or similarly with like policies and things, they might have redundancy and they might have all sorts of backups and things in place, but it's up to the healthcare organization to also ensure that there's a business continuity plan in place. So if the system does go down, what do you do? Do you switch to paper? How do you do that? And those sort of things. So in doing so, again, the healthcare organization needs to create a risk management, clinical risk management plan, a hazard log, and a clinical safety case report. So to achieve compliance with these standards at a really high level, this is sort of basically a diagram of the things that you need to do. You can dig down into each of those and get a lot more detail, but essentially you need to have a clinical risk management process that sits at an organizational level. You need to have a nominated clinical safety officer. You need to undertake a risk assessment, and you need to continue to assure that particular system post go live, post deployment. So some of the key requirements within the standard. So you need to nominate a clinical safety officer, and that clinical safety officer needs to be suitably qualified and experienced. They have to be a clinician. They have to hold a current registration with an appropriate professional body, and they have to be knowledgeable in risk management and its application. The clinical safety officer is responsible for ensuring that the processes defined in the clinical risk management process or system that you have as an organization are followed, and they must approve the plan, hazard log, and report. They don't have to author them, but often the CSO is the person who ends up authoring these documents too. What's really important here is to distinguish the difference between responsibility and accountability. The clinical safety officer is responsible, but they're not accountable for clinical safety. Accountability ultimately lies with top management, the senior leadership team. So they're ultimately they're ultimately accountable for ensuring that whatever they're procuring and going live with is safe. So I don't know, as an organization, so what I've done is I've tried to separate some of these things between what is required at an organizational level and what is required at a specific product level. So at an organizational level, running across all of the health IT systems that you might have, you need to document a clinical risk management process or system. The standards use those terms interchangeably. So this sets out your approach to clinical risk management and recognizes the sort of activities that you're going to do. You need to ensure that the manufacturer and the health IT system that you've procured complies with DCP 129. So that is a requirement on the healthcare organization, that you check and you ensure what you're procuring does comply, and DTAC basically helps you do that. Top management specifically have responsibilities to ensure that there are sufficient resources available for these activities, that they've assigned competent personnel, and they will be the ones who authorize the deployment and use of the health IT system and accept any residual risks on behalf of the healthcare organization. At a product level, you need to have a clinical risk management file. So this is going to contain all the formal documents, so all the deliverables like your plan hazard log and safety case report. It's also going to have any evidence of compliance with the standard in there. So within that file, you're going to have a clinical risk management plan. That's going to have your scope of what you're going to assess. It's going to have your risk acceptability criteria, the personnel that are going to be involved, the methodology you're going to use. You'll have a hazard log, which identify any hazards to patients, any sort of causes that trigger any of those hazards, and the controls that mitigate for those, as well as any supporting evidence for those, and an estimation of the clinical risk. Then the clinical safety case report summarizes all this activity and summarizes the process and assessment that you've undertaken and provides the outcomes and findings, and it references all the supporting materials you used. And that's the document that helps you communicate the assessment and its outcome to users, top management, and any other relevant stakeholders. The safety incident management log really comes in when the product is then live. So any incidents or issues are logged in there, and that obviously provides some effective communication and helps archive all these incidents. So in terms of a good approach, I think the first thing I'd say is really important is the culture. And that's driven by the top management or senior leadership team. And having them have the buy-in and the commitment to it makes a big difference. So when you have organizations that have that top management commitment, that have that organizational understanding, typically they tend to get these things right, these processes right, and helps them define a process that's integrated across what they do, and it's effective. Like we said before, accountability and responsibility is really important. And sometimes you'll find that accountability is placed on a particular committee that makes the decision to sort of do something or live with something rather than an individual. And that sometimes dilutes that accountability a little bit, but it's more effective when you have an individual, someone from the senior leadership team or top management, as the standards refer to them, who is ultimately accountable, a named individual, and that usually helps. And then, of course, communication and cooperation, not just within the healthcare organization, but with your manufacturer. So not just at the initial stage where you're getting the hazard log and safety case report from them, but when there's been updates, if there's issues, if there's incidents, any sort of thing that you need to go back and forth with, that's really important. And then lastly, there's a requirement to be commensurate. So the level of rigor, resource, granularity you're going to conduct an assessment with, whether it's a trust-wide EPMA system compared to if it's a simple app in a particular department, are going to vary greatly. And the standards recognize that, and it's important that you have a commensurate level of work depending on the risk profile. At a product level, I've highlighted hazard log workshops as being really important. So having the appropriate people in that room, whether it's from the various clinicians who are going to be impacted, whether it's going to be people in the IT department who are going to be involved, and having someone who can effectively facilitate these sessions so that everyone can take part. There isn't, the same people answering all the questions. People can raise concerns. That's a really useful exercise to have. And because clinician time particularly is so limited and so difficult to get a number of different clinicians together, in a room for a workshop, deciding at what stage you conduct these hazard log workshops is really important, because you're not usually able to run several of them. So there are different stages at which you can run a hazard log workshop. You can have it right at the discovery stage where you sit down and you think, okay, what are the hazards? What are the failure modes that we need to go through? And it's a bit of a brainstorming exercise. Or is it at a point where someone's drafted an early bare bones of a hazard log and you sit through and you try and put some more detail on there? Or you might do when you've got a complete draft and you're going through and going, okay, have we covered all of our causes and hazards? Have we covered all the mitigation? Or it might be right at the end where you have a hazard log and you're doing the risk analysis, the risk evaluation, the risk benefit analysis, and those sort of things. So I just wanted to run through some key hazards to consider when you are assessing a product. Now, most of these hazards you likely to see on the vast majority of health IT systems. So pretty much every health IT system is going to have an unavailability hazard. You know, what happens if there's a network failure? What happens if there's a service outage? Or there's a loss or corruption of data? Or you just lost access to it for whatever reason. Think about if you have adequate change management and support. What's going to go on during go live? Is there going to be floor workers? Are there going to be enough people there? Have you defined the processes and SOPs? Do you know, and does everyone know within the organization how what they're going to do is going to be different, what the new processes are? Training, obviously, really important. So have you got enough resource? Have you got enough material? Has the manufacturer provided you with a training environment? Have you got you know, a non-live environment that users can go in and train how to use it? I had an incident in one of my former trusts where, as part of training, someone inadvertently managed to log into a live system rather than the training domain and prescribe medication for a patient. So is it properly locked out? Have you got different passwords for them? Are staff released from their clinical duties to undertake training? And then there's things like configuration. There's a lot of these systems now are very configurable. How do you manage that configuration? How do you keep on top of it? How do you assess it? And then think about testing, like user acceptance testing. So they're just some to consider. So lastly, some of the common challenges. This is starting to change more recently from some of my experience, and I've seen more and more so the clinical safety requirements being included in contracts that healthcare organizations are signing with manufacturers. So, you know, is there something in there that says if there is an unacceptable level of risk for a particular part of the system or something in the system, then they have to fix it, for example. If that isn't there, and traditionally that hasn't been there, then that's a big challenge. How do you get manufacturers to listen to your concerns and change things within the system that you feel are a risk? And often with these sort of things, they're seen as tick box exercises. You know, people just look at the endpoint and want to sign them off. But it's that process that you go through, the assessment that you do, that's what's going to ensure safety rather than that endpoint where you sign something off. Another thing that's really common is the sharing of safety cases. Now, they're good to give you ideas and to give you a starter for 10, but remember that each implementation is unique to that healthcare organization, their own way of doing things, their staff. So sometimes you see people just almost copy and pasting these safety cases and hazard logs, and that really defeats the point of doing an assessment, an effective assessment. We've talked about top management engagement and accountability. High staff turnover, certainly in healthcare organizations. So there was one project I worked on, and in the space of 12 to 18 months, they went through 3 different clinical safety officers, and that's a huge challenge. You know, every time someone else comes in. And are those clinical safety officers got enough support and resources? The level of granularity, so that's the, you know, the commensurate requirement. And then lastly, ideally, all these things should be done prospectively. You know, you should be there involved right at the early stage, looking at the design, looking at how you're implementing things and ensuring that you have an input in that. But they're done retrospectively, which is challenging. And that is it. Got about, I think, 5 minutes for any questions.
Thanks, Hoddy. There has been there's a question in the chat that is it Rupesh? I don't know if you want to come off mic, or I'm happy to ask Hoddy. It's around the DTAC is changing to NHS DA tech and digital assurance requirements, and they're asking, is it correct, or are these 2 separate requirements?
Ooh, so I know that that whole thing is being looked at and it's being reviewed, as well as the standards currently being reviewed as part of a consultation. I'm not aware that it's already happened, but I might be wrong, so not sure. I'll try and find the answer to that and get back to them.
Yeah, if you just when you get a chance to have a look into it, we can always add it onto the futures page after the webinar, Hoddy. Are there any other questions for Hoddy, or if you want to come off mic, feel free to. I guess, are there any, from your experiences, Hoddy, is there anything that's been really key when you've been in part of one of the sort of clinical safety workshops around, like, for example, the hazard log? Is there anything that comes to mind?
I mean, I think we've covered most of it in the presentation, but yeah, so some of the really big projects that I've been involved in, the challenges have been when you've had lots of stakeholders, lots of turnover, and then that's led to confusion and lack of clarity about what it actually is that you want to achieve, what's the design of the system that you want. So recently we did the independent prescriber pathways program. We did a 160 on that, and that was something that actually ran quite smoothly. We had a hazard log draft that we ran through with a number of ICBs, and then we gave them basically the start of a 10 and said these are the sort of the high level things that we'd consider, and then handed it over to them to say, like, okay, now for your unique implementation, you ensure you add in whatever you think you need on top of that in terms of, are there any extra causes or hazards? And there were certain mitigations and evidence that they need to add on top of that. But at a really basic level, it's about ensuring you have a suitably trained and qualified clinical safety officer, and you have that sort of top management buy-in.
Oh, that's great. Thanks, Hoddy. And thank you for the presentation. We're going to move on to our next speaker. And I'm pleased to welcome John. John is a senior clinical lead in the digital medicines team at NHS England, having joined the team last year in August. John is a pharmacist by background with a clinical specialty in antimicrobials. Before he joined NHSE, he led an EPMA implementation and acute trust before taking on the role of head of clinical systems. John's going to talk to us about the electronic prescribing learning lab. So I'll hand over to you, John.
Thanks, Amna. So thanks for having me today. So I'd like to give you an update on the ePrescribing Learning Lab development. And I'm happy to take any questions after also. So the Learning Lab, if you're not aware, it's going to be a national learning resource comprising of a suite of support materials which will be hosted online and will be intended to support the optimization of e-prescribing systems used in secondary care. And that also applies to mental health, community secondary care organizations too. It's going to be intended to be specific enough to be useful and to define what good looks like, and to support organisations in optimising, but also broad enough to be applicable across the NHS to different health IT systems and care settings. So it will draw upon a broad literature review, as well as input from lived experience from subject matter experts, organisations around the NHS. There is a development focus group that is taking place today. Actually, that was advertised at the last Masterclass, and that is intended to identify broadly the themes that the resource needs to cover. Part of the resource will include case studies covering real examples of e-prescribing optimization and stories from across the NHS, and there is still an opportunity to get involved with that. So I've included the email address for our project manager, Michelle, and I'll drop that email address into the chat as well. So please do get in touch with Michelle if you feel like you've got a good story to share there. I should mention that the resource is expected to be available in the autumn. We don't have a firm launch date just yet, and we'll give an update again to this group in the summer. So any questions at all?
Has anyone got any questions to John about the project? So just, John, in terms of the focus group that's happening today, is it varied in terms of who will be attending in terms of stakeholders?
Yeah, we have got some quite good variation actually. So lots of different systems are represented, which I think is quite important. We don't just want a narrow cohort of users that use particular systems. And also there's plenty of people from mental health and community that are coming as well as acute. So I think we'll get a good overview of themes from that.
And there's a question in the chat around, would this be made available to Irish sites?
Well, it will be hosted. Well, I mean, where exactly it'll be hosted isn't quite known yet. The ideal is that it will be simply public facing, and it may well be hosted by the organisation that we're partnering with to create this is Newcastle, and it may well be that they host it, and obviously we can put links to the material in various different places. We prefer not to host it behind a login if we can possibly avoid that. So in that perspective, yeah, as long as we can do that, it should be available to anyone that wants to use it.
Oh, that's really, really helpful, John. And then just finally, so in terms of sharing, and I think you said you'll come back to the ePrescribing Masterclass. So in the summertime, is that to share the work from the focus groups?
From the focus group and the literature review, and essentially where the whole thing's up to. But we won't have the finished product by the summer, but we should certainly be much closer to it. So I can give you an update then.
Oh, that's really helpful. Thanks, John. And if anyone does want to get involved, John has put Michelle's contact in the chat. So please do email Michelle if you'd like to get involved. So I'd just like to thank all of our speakers today. It's been great to see so much variation and the questions that you've asked as an audience. In terms of this session, it has been recorded and it will be added to the future site probably at the end of this week. With that, we'll put any outstanding question answers on there, so you'll be able to use them. And you'll also get a certificate, which will be emailed to you from today, well, after today's masterclass. The next masterclass is on Wednesday, the 30th of April. There's a QR code on screen. So if you could use that either to sign up for the next masterclass, and Sarah's also put in a chat the direct link as well to the registration page. And I would say if you do have any ideas for future topics or even feedback from the masterclass sessions themselves, please do contact Sarah. Her email's in the chat there. And it's always really great to get feedback from you as an audience and insights to, any topics you'd like to see being presented on the masterclass. And also, if you do want to present yourself as a speaker, if you contact Sarah, she can send you out the dates that we have lined up for the future. And it's great to get, multi-professional speakers, pharmacists, nurses, doctors. We like to see lots of variation. And it's a real opportunity to share, I guess, the great work that you've been doing in your organisations and to allow others to fast follow. And before I close, if there's any, I'll just check, are there any final questions from anyone? And I'll take as a no. And also, the future masterclasses are going to be held on Microsoft Teams now. So I hope you've all found it easier to join today without any issues. And I'll close the event now, but it was great to see you all. And thank you once again to all of our speakers. And I look forward to seeing you again in April. Thank you.
Thank you.
Thank you very
much. Bye.
Bye.
Thank you.